Okay. Respected moderators and honorable expert panelists and learned audience, Assalamu alaikum. So I'm going to have a talk on the cardio-renal syndrome. From the point of view of the critical cardiology, so we often find the patient with acute decompensated heart failure who develops gradually acute kidney injury. So these are the patients of cardio-renal syndrome type 1. So in an observational study in National Heart Foundation Hospital and Research Institute, we found 41% of those patients develop type 1 cardio-renal syndrome. If to define, so cardio-renal syndrome comprises a number of, okay. Okay, cardio-renal syndrome comprises a number of conditions involving both the heart and kidneys, in which acute or chronic dysfunctions in one organ may induce acute or chronic dysfunctions in other organs. So in addition, both heart and kidney functions can be impaired by an acute or chronic systemic disorder. So cardio-renal syndrome can be classified into 5 types based on the chronicity and the primary organ dysfunctions driving the syndrome. So there are the 5 types. Type 1 CRS, which is acute cardio-renal syndrome. For example, heart failure results in acute kidney injury. Type 2 CRS or chronic cardio-renal syndromes, where the chronic heart failure results in chronic kidney disease. Type 3 CRS, what is also called acute renal cardiac syndrome, when the acute kidney injury results in acute heart failure. In the type 4, it's a chronic renal cardiac syndrome, and the type 5 is a secondary cardio-renal syndrome when the systemic process results in heart failure and kidney failure. So underlying pathophysiology of cardio-renal syndrome, actually in the acute setting, we know that patients with acute heart failure, they have the 2 hemodynamic profile. One is with low cardiac output, that is called dry heart failure, and often coexist with the venous congestion or systemic congestion when it is called wet heart failure. So all these mechanisms actually leads to the sympathetic nervous system and renin-angiotensin-aldosterone activation. And on the other hand, increased central venous pressure caused renal venous congestion, and thus the renal perfusion also impaired, and which leads to the tubular damage and glomerular dysfunctions. And among the non-hemodynamic mechanisms, oxidative stress, inflammations, where cytokines releases, an imbalance of nitric oxide and reactive oxygen species, mitochondrial dysfunctions, and endothelial dysfunction leads to the tubular damage and glomerular dysfunctions, leading to the acute kidney injury. In the acute renal cardiac syndrome, acute kidney injury worsens the acute heart failure with the bias, sympathetic nervous system, or RAS activations, and the harmful effect of the uremia, electrolytes disturbance, acidemia, etc. So I'm not going to talk over the chronic renal syndrome, chronic cardio-renal syndrome. So let's look at the cardio-renal syndrome and the COVID. As a Professor Robeda sir and Professor Mujibur Rahman sir has beautifully explained everything. So, but in the COVID era, an epidemiological study suggested that 36.6% patients with COVID-19 had different degrees of AKI. It has been reported that up to 29% of the intensive care unit patients developed during AKI during COVID-19. So mechanism, the cardiac involvement already been beautifully explained by Professor Robeda sir, but initially it was thought that the direct injury of the kidney doesn't occur, but nowadays it's lots of studies are in favor of the direct kidney injury. So during the SARS-CoV, the kidney damages include sepsis, cytokine storm, and direct cellular injury. And also there might be acute cardio-renal or renal-cardiac type of cardio-renal syndrome. And so Marguerite Apatry and rightly described involvement of kidney in COVID-19 as a brand new cardio-renal syndrome rather than type 5 cardio-renal syndrome. So diagnostic strategies, we needs to be presence of signs and symptoms along with evidence of a structural or functional abnormality of the heart and kidneys. And lots of emerging biomarkers are available right now. So let's look at the biomarkers. We know that cardiac troponin and BNP has a diagnostic value of acute coronary syndrome as well as heart failure. When it is combined with the kidney biomarkers, it definitely has a diagnostic value of cardio-renal syndrome. It's also give us a prognostic value of cardio-renal syndrome, even chronic kidney disease. So these are the kidney biomarkers. We know that serum creatinine, albuminuria actually help us to diagnose the AKI and also the cardio-renal syndrome. The cystatin C, it's also give us a prognostic value of cardio-renal syndrome. And among the other biomarkers of tubular injury, TIMP, serum NGL, urinary GL, NAG, and KIM1 give us the prognostic value. Among the imaging modalities, echocardiography should be done. It also helps us in diagnosing anatomical and functional abnormalities. Congestive state can be measured by hemodynamic parameters, including central venous pressure, systolic PA pressure, pulmonary capillary wedge pressure, left atrial pressure, and cardiac output. Venal ultrasound and venous flow patterns are emerging tools in identifying venous congestion. Cardiac MRI is the standard non-invasive method of assessing ventricular dimensions and functions of fibrosis. So treatment strategies in the acute cardio-renal syndromes, decongestive therapies are the cornerstone, and loop pyrotics represent the primary class. So whether to start with bolus versus continuous or low dose versus high dose, in those study showed no significant difference in patient symptoms or change in renal functions, but there was a trend in favor of high dose regimen. So the stepwise algorithm aimed for a 24-hour urine volume between 3 to 4 liter with furosemide suggested. Ultrafiltration actually used in the diuretic resistance fluid overload or refractory cardio-renal syndromes. Though there is the unload trial actually showed significant weight loss, but did not show the improvement of symptoms of dyspnea, and where the CRS heart failure study showed there is no significant difference in weight loss were noted between the two groups in diuretics and the ultrafiltration group. Neurohormonal modulation, tolvaptan and nesiritide actually used for the decongestive therapy, though they induce a weight loss, but they do not improve the symptoms of dyspnea. About the inotropes, low dose dopamine showed no long-term clinical improvement and renal protective effects. Low dose dopamine improves urine output, but no significant differences in change in creatinine, rehospitalization, or mortality. Renal replacement therapy, the decision to initiate urgent renal replacement therapy in critically ill patients with AKI or CRS is based on the standard AEIOU, meaning acidosis, electrolyte derangements, intoxications, volume overload, and uremia. But when to start, there is debate, but patients with AKI who do not have a specific indication for renal replacement therapy, initiation may safely be observed initially, even in the presence of oliguria, for example, urine output less than 400 to 500 milliliter per day. So these are the modalities of renal replacement therapy, but in the hemodynamically unstable patients, slow and low efficiency dialysis and CRRT should be tried. So about the chronic cardio-renal syndromes, these are the drugs which actually has a mortality benefit, and recently SGLT2 inhibitors, despite of with or without diabetes in heart failure patients, should be used. So I'm not going to go through this device therapy, but in the chronic heart failure patients, the CRT, ICD can be used. And in the acute condition, we often give the patients mechanical circulatory support, especially about the impella, which actually Flaherty et al. Demonstrated a reduction in the AKI rates with impella 2.5 support during high-risk percutaneous coronary intervention. So now the last slide, it's about the prognosis. So in a retrospective cohort study in a large healthcare system, acute cardio-renal syndrome type 1 and type 3 was associated with the highest risk of death compared with chronic kidney disease without cardio-renal syndrome. And patients with cardio-renal syndrome type 4 had better survival. And 16% of the patients with type 2 CRS and 20% of patients with type 4 CRS developed acute CRS, whereas 14% of patients with acute CRS progressed to CKD or chronic heart failure, decreasing left ventricular ejection fraction, increasing pulmonary arterial pressure, and higher RV diameter were independently associated with higher incidence of CRS. And with this slide, thank you. I should stop here.